Okay, so now I'll tell you about bladder cancer. Okay, so bladder cancer can be of three types. It can be either transitional cell carcinoma, it can be squamous cell carcinoma, or it can be adenocarcinoma. Okay, so transitional cell carcinoma, the risk factors, okay, you can remember it by the C. Okay, transitional cell, that is the cigarette smoking, then cyclophosphamide, okay, then chemicals, okay, which chemical? It's a dye called as the aniline dye, okay, aniline dye. So these are causes of transitional cell carcinoma: cigarette smoking, cyclophosphamide, and aniline dye. Second, squamous cell carcinoma. So this you can remember by yes, okay, same thing, cigarette smoking. Then you have also schistosomiasis, okay. And then in adenocarcinoma, where is it seen? It's seen in the region of it is persistent urachus, okay, urachus, and at the trigon. Okay, so these are the three types of and the causes of bladder cancer. Now coming into the genetics. So what is the gene associated with it? It is the NAT2 and GSTM1. Okay, so this is a germline markers for bladder cancer. NAT2, okay, NAT2 and GSTM1. Okay, now third one, what are the clinical features? Okay, so clinical features is that there will be gross painless hematuria. Okay, gross painless hematuria. Now what is the investigations that you will do? Okay, so first you do an USG KUB. Okay, so what all you can see over here? You can see a growth where? In the bladder. Okay, you can see a growth in the bladder. You can see clots, and also you can see for the status of the kidney. Okay, then second, what you can do is you can do urine routine and microscopy. Okay, routine and microscopy. Then third, what you can do is cytology. Okay, cytology has low sensitivity. Now how do you confirm the diagnosis? Okay, so you confirm the diagnosis via cystoscopy. Okay, cystoscopy, and via cystoscopy you can resect the growth. Okay, so what is that called? It is TURBT. What is that? It is trans urethral resection of bladder tumor. Okay, and once and after that you can do cold cup biopsy. Okay, you can do cold cup biopsy, and then you can determine the T staging. Okay, and staging you can do via the MRI. Okay, so this is transurethral resection of bladder tumor. Okay, then you can do cold cup biopsy and determine the T stage, okay, by MRI. Now coming to the staging of bladder cancer. Okay, there are 4 grades of bladder cancer. Okay, so first one is TX. TX means what? Primary tumor cannot be assessed. Okay, then second one is T0. T0 means there is no evidence of tumor. Okay, then third one is TA. What is TA? It is non-invasive. Suppose if this is the bladder, okay, it has not invaded. Okay, it is non-invasive papillary. Okay, papillary carcinoma. Then TIS is carcinoma in situ. Now coming to the T1. Okay, T1, T2, T3 and T4. Okay, you have T1, you have T2, you have T3, and you have T4. So what is T1? T1 is if it involves a subepithelial connective tissue. Okay, it involves a subepithelial connective tissue, which is this lamina propria. That is T1. What is T2? T2 is if it involves the muscularis propria and the bladder wall. Okay, so this is T2. If it involves the bladder wall and the muscularis propria, it is T2. Okay, T2A and T2B is there. Okay, so T2 has two things, T2A and T2B. A is it if it involves a superficial muscle, that means the inner half. Okay, inner half. And T2B is if it involves the outer half, okay, of the bladder wall and the muscularis muscle. Then T3. T3 is if it involves the perivesical tissue. Okay, so perivesical tissue. Then T4. T4 also has T4A and T4B. What is T4A? T4A is if it involves the prostate, uterus, or vagina. Okay, T4B is if it involves the pelvic or abdominal wall. Okay, so this is prostate, uterus, or vagina. Okay, so this was about the TNM staging. Then grades, there is grade 1, 2, and 3. Okay, grading is 1, 2, and 3. 1 is well differentiated, 2 is moderately differentiated, then 3 is poorly differentiated. Okay, then there is something called as a PUNLMP. What is a papillary urothelial neoplasm of low malignant potential? Now, how do you manage it? Yes, you already said it is by TURBT, transurethral resection of bladder tumor. Okay, so you see, it can either be superficial or it can be advanced. Okay, advanced involves a deep layer. Okay, that is, it invades a muscle layer. So if it is above the muscle layer, so we said T2 is if it involves the muscle layer, right? So superficial means above muscle layer. Above muscle layer means which all? TA, T1, okay, T1 and TIS. Okay, so this is all above muscle layer. Okay. And how do you manage it? If it is TA, TA is what we said, it is non-invasive. So here what you can just do is observation, and you can do, okay, okay, so for TA what you can do is a single intravesical chemotherapy of thiotepa, okay, thiotepa, then adriamycin, and mitomycin C. Okay, then T1. Okay, for T1 what we said, it involves the lamina propria, right? So here it involves 6 weeks of intravesical, okay, vesical chemotherapy, or you can give BCG immunotherapy. Okay, so 6 weeks. Then TIS, that is carcinoma in situ. For this it requires 6 weeks BCG. Okay, then for radical, okay, cystectomy, then you require 3 monthly checkups, cystoscopy, okay, and like that. So for coming to advanced bladder cancer, this is all superficial bladder cancer above this thing. Now coming to the advanced bladder cancer. Advanced bladder cancer, we said it is T2, T3 and T4. Okay, so T2 you have to do a radical cystectomy, okay, followed by radiotherapy. Okay, then T3 and T4, what you have to do is, first you have to do neoadjuvant chemotherapy, okay, followed by surgery, and then you have to do radiotherapy. Okay, so what is the chemo drugs you use? It is called as a MVAC regimen. Okay, MVAC regimen. What is MVAC? Methotrexate, vinblastine, or doxorubicin, or adriamycin, and cisplatin. Okay, so what are methotrexate, then vincristine, then adriamycin. Okay, adriamycin or doxorubicin. Cisplatin. Okay, this is called the MVAC regimen for bladder cancer. Okay, now we said we can do partial cystectomy and also radical cystectomy. Okay, partial cystectomy is when if it does not involve the ureteric orifice. Okay. So coming to the surgery. Okay. So surgery, there is partial cystectomy and also radical cystectomy. Okay, partial and radical. What is partial? Partial is if it does not involve the ureteric orifice. Okay. Okay, so here what happens is a tumor is at the dome. Okay, tumor is at the dome and it does not involving ureteric orifice. Okay, and here it is solitary lesion. And what about radical? So radical, what all you have to remove? You have to remove the bladder, then you have to remove the iliac and obturator lymph nodes. Okay, and in females the urethra is removed. Okay, then in males the prostate is removed. Okay, and so you have to remove all of that, then followed by urinary diversion. Okay, there can be continent and non-continent. Continent is if you form a new bladder, okay, via the ileum. Okay, ileum you make a neobladder. Okay, so the most common you will do is the non-continent. Okay, so what you do over here is the ureterosigmoid anastomosis. Okay, ureterosigmoid anastomosis, and also there is something called as the ileal conduit. Okay, so what are the complications of this ureterosigmoid anastomosis? So ureter is going to a sigmoid, right? So there can be increased risk of UTI and adenocarcinoma and hypokalemic, hyperchloremic metabolic acidosis. And this ileal conduit is the most common. So what you do is, suppose if this is the ileum, okay, so okay, so you take this part of ileum, okay, and so you combine the ureter. Okay, so what can happen over here is there can be stricture at the site of anastomosis. Okay, so this was about the bladder cancer. Okay, so these are the causes, then genetics. Okay, NAT2 GSTM1, then clinical features, gross painless hematuria, then investigations. Okay, then confirm by cystoscopy, resect the growth, transurethral resection of bladder tumor, and coming to the staging.